Good afternoon, ladies and gentlemen. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your host, Christine Micah, Improvement Lead at CFHI. Please go ahead.
Hi everybody, and welcome back to the Better Together e-Collaborative. This is our Phase 2 webinar, and we've got a full agenda today. So without further ado, let's just jump right in. While I introduce who's on the call today, if you haven't already done so, please introduce yourself and where you're dialing in from today. My name is Christine Micah, and I'm an Improvement Lead with the Foundation. Here in the webinar room with me today in Ottawa is Jessie Checkley, and she'll be helping to facilitate some of our question and answer periods. Eleanor Revoir is here with Patricia O'Connor and Angela Morin, and they will be delivering some of our quality improvement, education, and communication content today. Her coach, Sophie Baillargeon, is also on the call to support your learning, and Marie-Suzanne Lavallée sends her regrets. A warm welcome to our patient and family advisors who are joining us on the call today with your teams. Thanks so much to everyone for being here. A couple of housekeeping reminders. By clicking the 4 arrows on your screen, you can enlarge the presentation to full screen mode. If you wish to return to the regular viewing mode, where you have access to the chat, please click that button again. We have designated question and answer times after all major topics. Teams can ask their questions in the language of their choice using the chat box in the bottom right of your screen. This webinar is being offered in both French and in English, so bear with us through our pauses as we transition from one language to another through our question and answer sessions. So Phase 2 of the Better Together e-Collaborative is really where the rubber hits the road. We will be touching on a number of theories, concepts, and frameworks, and in doing so we hope to expose you to some possible helpful tools, and we'll leave it to you to further explore concepts of interest in greater detail. In 2 hours, it's not possible to dig deeply into all of the concepts and theories in these subject areas, but supplementary learning activities and templates that are provided on the desktop should supplement your learning. We've taken your feedback from previous surveys and polls and hope to continue to tailor our offerings to what you have identified as needed for your implementation project to be successful. Today we'll be spending time on consultation and consensus building, communication, and education. The topic of measurement will also be explored throughout, and I would like to let everybody know that the Better Together measurement plan is now available on the CFHI desktop. This plan outlines the measurements we have promoted you to begin thinking about in your current state report and can serve as a template to guide your measurement planning and data collection. This resource is presently listed as a resource under the webinar and will also be included in your end of Phase 2 reporting template. We have built in a 5-minute break midway through the 2-hour webinar, so thanks very much for staying with us until then. I wanted to take a moment to remind everyone where we are in the collaborative. As of September 1st, we've entered into Phase 2 of the e-Collaborative, which is really about formulating the family presence policy and doing your implementation planning. Phase 3 will begin in the new year, at which time teams will begin implementation of their family presence policy. We wanted to share back some feedback from what we've heard from teams submitting their current state reports. You may recall completing the Readiness to Receive self-assessment, which asks teams to critically reflect on barriers and opportunities within their organizations that will help or hinder progress. So here's a summary of what we are hearing from you. Overall, leadership alignment is very strong, especially when it comes to the aspects of sponsorship and leadership. There were some challenges with alignment with strategy, goals, and priorities. And regular communication with all stakeholders will help to reinforce family presence policy alignment with existing strategic priorities and goals. While still rated quite favorably, infrastructure and organizational culture were the two lowest rated areas, rated 2.4 out of 4. Within the organizational culture subsection in particular, you've identified challenges around training and measurement as well as monitoring. So we'll touch on some of the opportunities for training, and we've also developed that measurement template I've previously referred to. That's available in the desktop. I did want to take the time to say that if you're looking for specific feedback on what you've submitted so far from your reports, please get in touch with me, Christine, and we can coordinate a call with CFHI and our coaches. We'll only be reaching out to teams where there's major flags or areas of concern that we've identified from your report. Here's the collaborative assessment scale that you might recognize from your mid-phase reports. This tool is helpful both to us at CFHI in designing the collaborative and as feedback on where teams are in their implementation of family presence. We hope the tool is also useful to you as a reflection tool for your team as you contemplate the elements that must be in place in order to implement and sustain family presence. On average, the report is saying that the collaborative as a whole is at 1.3, and this is out of the scale of 4.5. This is exactly where teams should be, as phase 1 of the e-Collaborative was about forming your teams and really just the starting place to planning for implementation. At the midpoint of phase 3 is where we really expect to see some movement and changes on this scale. At this time, I'll now pass things over to Angela, who's going to kick off our content for phase 2 by leading us through the NHS Sustainability Guide as we think about the different elements that need to be in place as we undertake this change. Angela, over to you.
Thank you, Christine. And hello to everyone. Great to have you all on the call. Hospital policies are seldom actually read by patients. They are lived by patients. For patients and families, policies come to life in the care that they experience within your organization. The Family Presence Policy may be one of the few exceptions to that. Families will read it, and they will expect their experience to reflect the intent of the policy. I remember running into a friend one day, and she told me about being at the hospital and how anxious she was feeling about leaving a loved one as they entered a patient area after what she assumed was the end of visiting hours. And the porter who was wheeling the patient's bed reassured her that she was welcome to stay and told her about the family presence policy. She was so impressed that he took pride not just in the tasks that he was doing, but that he cared enough to ease her anxiety and was so proud that KGH had that policy. So, you're formulating a new family presence policy and changing or growing your culture to one where you partner with families in the care of your loved one. Easy, right? Here's the thing. As you've all realized by now, the actual physical act of writing the policy is the easy part. There are numerous pieces that are integrated, that are pieces to the puzzle, that must be given attention from the very beginning of formulating the family presence policy. This planning may at first glance appear to come later in the process, but in fact it must be done from the very beginning. The process of implementing change is critical to the success of not only implementing a family presence policy, but formulating it, and will affect many different aspects of the organization. It is critical to be aware of the importance of some key elements in implementing change and planning for sustainability to ensure that the intent of the change in policy is understood and demonstrated in the behaviors of those who must implement it. Planning for sustainability is truly foundational to the success of this change in your organization and needs to be considered from the outset. There are different resources and guiding frameworks to help you to identify strengths and weaknesses in your planning, to support the implementation and to improve the odds of success in sustaining the change. Although it's important to find a model that fits your needs, most frameworks will have similar elements that they suggest for supporting change. For today's webinar, we're going to refer to the National Health Service Institute for Innovation and Improvement, the NHS, sustainability model. We've chosen this model because it addresses most of the key elements that you will want to consider. The NHS's sustainability model has grouped 10 factors into 3 interconnected domains. The process domain includes factors such as the monitoring of progress, assessing adaptability, and the credibility of evidence and benefits beyond helping patients, such as increased efficiency or making someone's job easier. Most of the factors in the process domain will have already been considered by your teams in phase 1 of this collaborative process. The organization domain factors assess the fit of the planned change with the organization's strategic aims and culture. How is the change contributing to the overall organizational strategic goals? And infrastructure. Does the organization have the facilities, equipment, trained staff, policies, and procedures to support the change? Again, most of these factors will have been considered in the planning your team did early in this collaborative. Today, we're going to focus on the factors that are situated in the third domain. In the NHS model, that domain is the staff domain. There are 4 key factors to be considered: staff involvement and training to sustain the process, staff behaviors and attitudes towards sustaining the change, and the support and commitment of senior and critical leadership. All 10 of these factors in the 3 domains are considered key determinants of sustainability. The combination of these factors will help you to build a solid foundation for your family presence policy and practice. But there's one more factor, a key element that is not reflected in the NHS model. Where are the patients and families in the framework? There's so much to be learned from the experiences of patients, and including them from the beginning can help to ensure that you are identifying gaps, addressing the right problems, and focusing on the right solutions. I was once in a patient advisory council meeting, and the program manager came in to discuss a challenge they were facing. The waiting room that they'd been using had to be repurposed for education and training, and they did not have another space that would accommodate that many patients. So they were going to have to get really creative with space and had come to talk to the advisors about that. And then an advisor asked, why are so many patients waiting? Why do you need a space that large? Should we not be looking at reducing the number of people waiting instead of finding space large enough to contain them? After all, keeping people waiting is not very patient-centered. That conversation changed the project from a redesign of physical space to partnering with patients in projects around patient flow, new patient referrals, scheduling, and communication. Patient and family advisors see things through a different lens. They challenge the status quo, they ask different questions, and change the conversation. They are key stakeholders in healthcare improvement, and it is critical that they be part of the process from the beginning and throughout the implementation. So with that in mind, we decided to adapt the NHS model to include partnering with patients, families, and patient advisors as another key factor in a new people domain. This factor will reinforce the involvement of patients, families, and advisors in the process. Things to consider might include, have they been encouraged and given the opportunity to express ideas, bring their perspective, and inform the change process from the beginning like other key stakeholders? Have they played a role in the development of tools to assist with the implementation? Is there training and development infrastructure in place to support them in participating in a meaningful way? Have they helped to define measures of success? How will patients and families know about this change? Adding this factor to the people domain connects patients and families to all of the domains. It ensures that there is focus on partnering with patients from the beginning and that they are embedded throughout the process and recognized as a key factor in the success and sustainability of the policy. So now that we know the key factors that need to be considered in the people domain, let's take a deeper dive into some of them. Patty and Eleanor are going to join the conversation to share tools and resources you may want to consider to support the formulation, adoption, implementation, and sustainability of your family presence policy. Over to you, Patty.
Thanks, Angela. In a survey that you completed prior to starting phase 1, it was at readiness assessment. You told us that change management is the #1 ranked topic area that would be most helpful to include in the e-Collaborative curriculum. You also ranked your knowledge of resources to support the adoption, implementation, and sustainability of family presence policies as 3.4 out of 10, the second lowest ranking of the 21 knowledge abilities assessed. And you ranked your ability to identify appropriate measures and change methods as 4.3 on 10. So again, it was clear that you all had some concerns about your skills and readiness in these areas. Given this, we wanted to take a few moments to briefly revisit the model for improvement, the theory of change that you will be using to guide your initiative, and how you can easily build in simple measurements to see if the changes you make are really leading to improvement. The model for improvement asks 3 key questions. First, what are you trying to accomplish? And that's your aim statement. Second, how will you know if your change is an improvement? And that really gets at your measurement plan. And third, what changes will you make to achieve your desired aim? Finally, the model for improvement is based on rapid cycles of testing your changes using Plan, Do, Study, Act. In any improvement work, one needs to have a theory of change guiding the choices you make to achieve that aim. Reflecting upon your underlying theory of change helps you deepen your understanding of the problem you want to solve, make your improvement methods more explicit, and reflect on the factors that are likely to influence the implementation and success of the improvement that you're proposing. To justify your course of action or why you're asking people to adopt specific changes, you need to consider the research evidence, your past experiences, and have analyzed your current state. In terms of your aim, you need to define what success will look like in specific measurable terms. The aim statement includes information about what will improve, such as the experience of care, by when and by how much, let's say by 10% improvement by March 2017, and for whom. And there it's the patients, families, and caregivers. Now, most of you have done this step in phase 1, that's clarifying your aim statement. But if you have not included each of those elements, the what, when, how much, and for whom, it's time to do that now. In improvement science, a driver diagram is a simple improvement tool to guide change. It's just not advancing. Could somebody advance it for me, please? That's, for some reason, it's not advancing when I click the arrow. It should be the next slide. The enemy of, yeah, perfect, thank you. In improvement science, a driver diagram is a simple improvement tool to guide change. It makes your theory of change explicit, and it guides testing, measurement, implementation, and ultimately your spread and scale plan. The driver diagram model is composed of 4 parts: the aim statement, primary drivers, secondary drivers, and the change ideas that you will test using PDSA. So what is a driver? It's an element of the system or a key process that will drive the outcome. Examples include things like structures, processes, operating norms. Primary drivers are the major factors to be addressed in order to reach your aim. So if your aim is to improve patient experience through changing your presence policies and increasing partnering with patients at the bedside, then you need to identify in those primary driver boxes what are the major activities, not all of them. Keep it simple. Don't go for more than 3 primary drivers. The secondary drivers is what's needed to achieve the primary drivers. And the change ideas are all the ideas that you and your team generate as possible ways to address the primary and secondary drivers. Again, these should be evidence-informed choices. As you work from left to right in a driver diagram, you're essentially explaining your impact theory, and you're answering the question of how you will achieve your aim. So let's take an example of wanting to reduce fall injuries by 50% by June 2017. The primary drivers would include things like ensuring a multifactorial risk assessment, such as MORSE, is completed at the time of admission, change in status, and after any falls. Another primary driver is consistent use of a fall prevention bundle of interventions, or for example, the Registered Nurses Association of Ontario's best practice guideline on fall prevention. A secondary driver for that intervention bundle would include training staff, patients, and family members in fall prevention. In terms of change ideas, your team may have several different ideas about how best to conduct the training for the staff, such as using videos, self-directed learning modules, mini learning sessions with unit champions. When you examine the driver diagram from right to left, again, I'm trying to advance it. There you go. Okay. You're really answering the why question. And in essence, it is your rationale for change and thus your change theory. The driver diagram picture is a useful tool to share with all your key stakeholders as a simple way of conveying what evidence you have examined and why these interventions have been selected. It's important to remember that the driver diagram is a working tool that will change over time. Do not wait till you have the perfect theory to get started. In improvement science, the process is iterative, meaning you will revisit the plan over and over and modify it as needed based on many tests of change you need to conduct. So learn and adjust as changes are tested, and shape the changes as frequent measurement feedback informs your theory of improvement. On a driver diagram, there should be measurements identified for each of the primary and secondary drivers. And this next slide is an example of a driver diagram for the introduction of family presence policies. So you can see the aim statement, and this might be something that is useful for you, or you will fill in those boxes for yourselves. What are the main change areas? But I've just developed this just to give you an example of, in this context, what a driver diagram might look like. So the aim statement in this case is that patient and family experience of care will improve by 10% following implementation of presence policies in January 2017. So how will you achieve that? I've proposed, or hypothesized, that there's three main drivers. The first is that staff and physicians perceive the value of family presence and demonstrate patient and family-centered care practices. So that's going to be measurable because you can do audits of those behaviors. Secondly, another driver is the new presence policy that would be developed with multiple stakeholder input. And the third is a communication plan with consistent messages. Some of the secondary drivers are then listed there, and I won't go through all of those, but it gives you an idea of how you break down or develop your logic model for how you're going to proceed. And in that far right-hand column, again, you'll have a whole slew of different change ideas. And the point here is, again, you want to derive these from the evidence, from the research evidence, from past experience, from other case studies that you've seen, but that have been implemented in this area. But you just need to test and see which ones will work best for your organization or for your pilot areas that you're starting with. A critical step in any successful improvement initiative is getting everyone on board. In the pre-phase one survey, that readiness survey, you told us that organizational and administrative barriers is the #1 identified theme that will affect the implementation of your initiative. As a group, you ranked the ability to create a stakeholder engagement plan fairly low at 4.3 in 10. Now that was at the very beginning, and we know that you've all done a lot of work since then. And so your skills have been growing. And you also said that physician and clinician engagement was mentioned multiple times when we asked about the barriers and challenges to adopting family presence. In healthcare, improving patient outcomes and their experiences of care are two basic goals that unite all of us, no matter what our job is inside the organization. It's the heart of what we do. So demonstrating how your initiative will do that is the first step. It's also important to provide a picture of the current state. Look at the data that you have about current performance, as well as where the gaps are in understanding patient, family, and caregiver experience of care. For example, you can ask yourselves, to what extent do patients, families, and caregivers feel that they are included as partners in care with their own lived expertise? You also need to be able to explain how this new presence policy is aligned with other corporate priorities and how working together will likely accelerate the goals of others. We all know there's a lot of different motivators to get things done. As an effective leader, you need to be mindful of both the intrinsic and extrinsic drivers. At the administrative level, the extrinsic forces are well known and include things like performance scorecards, government monitoring, and pay for performance. In the case of new policies related to family presence and building partnerships in care delivery, there's a very strong alignment with the most recent changes at Accreditation Canada, where person and family-centered care is a key focus. But the most important area to dedicate time and energy is on engaging the hearts and minds of your staff. People rarely do things just because of the extrinsic forces. It's our core values and beliefs that drive most of us, such as wanting to make a difference or to ease suffering. So think about how you can create opportunities for staff and physicians to share examples of when family presence made an important difference and what they as an individual did to make things better for the patient and family. Before today's webinar, we asked that you view the YouTube video on stakeholder engagement that featured myself and Dr. Samir Sinha from Mount Sinai in Toronto. This included information about the types of stakeholders, the role each plays, whether they're likely to support your work or not, and how to build a wide range of engagement strategies. And this table should look familiar. In phase one, we asked you to complete the blue part of the grid. In the pink sections is the work you now need to focus on and prepare a more detailed work plan. And we realized that in many cases you've already been working a bit in the pink zone there. But really what you need to be identifying are the potential barriers that you're going to be facing, the key messages to communicate to each stakeholder group based on their level of interest and influence. Consider what the program needs from that stakeholder. In preparing for your time with each stakeholder, first answer the question, what's in it for them? You really need to translate your initiative, goal, and aims into their language and their preoccupations, not what necessarily is on your mind, but what you know is their agenda in terms of change and improvement. Then articulate the outcomes that you expect to see to successfully design and implement your initiative. For example, if you look at senior admin, key committees, council of physicians, some of the kinds of messages are about the alignment of family presence to other corporate policies, and that it will improve patient safety, increase work satisfaction, and improve patient experience of care. Those are the kinds of things that matter at the senior level. The next column is where you can list the specific strategies or methods you'll use to communicate your project. If the stakeholders are your board, senior management, community partners, and groups like councils of physicians, you'll want to consider doing a presentation to the board, a press release, developing a PowerPoint roadshow that can be tweaked for each audience, and really importantly, get onto standing agendas of your key or your core hospital committees, whether it's operations, leadership, whatever it's called. Get onto the standing agenda so that you're able to give, not just one time, but every month you can give an update on where things are. Last is to plan the timing and dates for each session. For really important stakeholders, such as your patient committees and your patient advisory councils, provide them with information about your aim and objectives and seek their participation, such as inviting one of them to co-present this initiative in all of the stakeholder groups that you meet with. Taking enough time to engage your frontline staff is perhaps the most essential step, and you're going to hear a lot more from Eleanor and Angela about that. Frontline staff are the ones who need to implement the new policy, and like patients and families, they should have direct involvement in how the policy is developed and the methods for how it is implemented. We wanted to leave time now to hear from you all about your stakeholder engagement process so far and what challenges you may be facing. So please take a few minutes right now and provide some feedback in the chat box. Again, just share with us what have been your experiences as you have been engaging with different stakeholder groups. And while you're doing that, I have a specific question that I'm curious about because it has been important in our organization when we were doing this work years ago. And that was, have you met with your union, particularly your nurses union yet? And how have those conversations gone? Thank you for your comment. Merci beaucoup, Jenny, the Réseau de Santé et Vitalité, who's indicated that they don't have many challenges right now. Further indicated that she's awaiting approval from the Board of Directors. Okay, that's good. So you've already approached them. I'd be curious to know as well if any of you have all had the opportunity to date to present this new initiative to your board, or whether that is on your plan, your stakeholder plan, to actually get some airtime at a Board of Directors meeting. And Kathy Stevenson from CIS de l'Outaouais has indicated that they have met with some of their program quality folks. That's great. Okay, your Quality Council and Patient and Family Advisory Committee, Board Quality Committee, fantastic. That's great. And as you're commenting, could you also just indicate whether how it's gone, whether you've had positive response, whether you've had any reluctance or resistance? It'd be helpful to hear about that.
And Patty, it's Christine here, I just wanted to pick up on Outaouais, who said that sharing some success, saying that the project has been met with enthusiasm and they'll be implementing across their 6 sites in Outaouais. So I didn't want to miss that one.
Fabulous. Fabulous. That's great. Oh yes, I see it there. I'm sorry, I missed that one. Across all 6 sites. That's fabulous. And at CIS de l'Outaouais, again, they've indicated that they have presented their plan to 2 groups of their senior leadership who will be implicated. Yes, who will be strongly implicated in the work. And they will be presenting to the comité, the Clinical Coordination Committee on October 4th. That's great. Gives you a little bit more time to get ready for that. And then we'll be following with the other councils and the board. And Jenny Toussaint has indicated positive responses, not much resistance right now, maybe when we start the implementation with employees and doctors. Well, it's great that you're off to a really positive start. That's very encouraging. And at Centre Hospitalier Université de Montréal, CHUM in Montreal, their board of directors will be met, will have been approved by the comité de direction, so near the end of January is when they're planning on doing that. So it looks like your plan is for that implementation to occur a little bit later than with some of the organizations. And at CHUM, right now, they're also in the phase of writing the policy.
So Patty, it's Christine. I'm in the interest of time, I suggest that we move on, but we do have a question and answer period that's coming up. So if those want to chat in and continue to type in your comments and questions, we're just a couple slides away, so we'll pick it back up. Over to you, Patty.
Thanks, Christine. Good idea. So very briefly, my last comment around the stakeholder engagement and everything that I've talked about so far is that you need to be thinking about, and if you haven't already finalized your measurement plan, you should be in progress with that. And that should include your process measures, outcome measures, and potentially some balancing measures. Examples of process measures could include things like, just in terms of stakeholder engagement, could include things like the percentage of core hospital committees that have been met with. If you said that you wanted to get to 8 of them, if you get to 4, if you're at 2 of those so far, you're at 25%. The percentage of staff who are surveyed. Other outcome measures might include things like the percentage indicating support of new policy and direction, and having an article in a local press is another outcome measure. So let me get back up now. So one major activity in phase 2 is to develop your new policy after you have completed the stakeholder engagement process and obtained feedback on how to make the initiative work better. Because the goal when you're going to those stakeholder sessions is not just to talk, it's really very much to listen and to really pose questions to each audience of what do you think about this, and how could the project be better if. So that better if is always a very useful way of engaging other audiences to hear about things that perhaps you may not have considered. In many ways, this aspect of the writing of the policy is one of the easiest activities. We suggest you might want to look at the Institute for Patient and Family-Centered Care guide on their website, as it provides useful information on what to include in the policy. While writing the new policy is relatively straightforward, keep in mind that there are other things that you're going to need to address in other parts of the system. For example, the mission and values of the organization. If there aren't explicit statements and commitments around supporting patient partnerships, this is the time to engage with your senior leaders around that. Job descriptions and performance review will need to be re-examined, because you will probably, if you do not already have it explicitly in there, that a responsibility is to improve patient experience of care, that needs to be added. You'll need to look at your website, at the information about family presence and partner and family presence and families as partners in care, and look at the signage throughout your facility. What not to do. We had an affinity call in phase 1 where we heard from St. Paul's Hospital, who gave us a great example of how they feel that they really used the wrong implementation timeline. They developed their policy quickly, and then they went and started implementing it, and they had not done the stakeholder engagement and all of those really critical conversations with frontline teams as well as middle and senior leaders. And they said it took them so much longer because they had to redo everything. So get things in the right sequence. So please, if you haven't worked out that implementation timeline, please do that now. And finally, remember that successful implementation is rarely a linear process. It's circuitous and it's messy. So Christine, just if you can just give a time check here, what amount of time is available still for any other questions or comments?
So Patty, we're good for time. We're a little bit ahead, so
Okay.
if there are questions, certainly please chat them into the chat box. Questions about what Patty's been speaking on in terms of the driver diagrams or some of your stakeholder engagement, we'd welcome those questions now.
And I'd like to ask a question of Shum. You said that you're in the process of writing the policy now, and I know when I read through the end of phase 1 reports from everybody who submitted it, I've noticed that there are at least a couple of other organizations who had started some of that policy writing. My question is this: do you have frontline staff representation in the group that is doing the policy writing? And just as people are typing, another point about the sequence of implementation. If you prioritize getting some of the really heavy hitters, I refer to them as sort of some of the most influential voices in the organization, like the board of directors and like the comité de direction, or the senior leadership, executive leadership team. If you prioritize to get to them at the beginning, if you've then got their endorsement, that goes a huge way as you then approach different stakeholders, because they know that you have gone and to the board and that you have that high level of endorsement and support to proceed on a go-forward basis. And that is worth its weight in gold. So as back in phase one, again, during one of the webinars, and then again in the webinar that we've asked you to review, you'll see in there the stakeholder grid of influence and interest, and you're really aiming for prioritizing the people that are in that upper right-hand box. Those are the folks who have high influence and power, as well as high interest. So Jenny from Réseau de Santé Vitalité has indicated that the frontline staff weren't there at the beginning, but they will be able to give their comments. So they have been consulted to get their feedback on the aim. And it's Shum. So there are frontline staff who are on the steering committee, the pilot committee, and in the second case, there's going to be a number of validations. In other words, repetitive times, I guess, conversations that will be occurring in an iterative way with the frontline, with the Council of Nurses, with the Council of Physicians, and the Multidisciplinary Council. As well as SHUM, two patient partners, as well as the Users Committee or the Patients Committee have been associated or integrated in the process as they go forward. That's great, Jenny, because they're obviously really, sorry, not Jenny, that's really great that that's really a critical step to get your Comité de Usage on board. Jenny from Santé Vitalité, the visiting hours are going to be enlarged and more flexible with a new policy and procedure. And the personnel, so I guess this is probably based on some conversations that you've had with staff, that the personnel have found that the families at the bedside are already facilitating care with the patients and involved in the improvement of care at the bedside. And it's indicating that she's already starting to see some changes in the culture. That's great. It's, really the most important message I think we're conveying here is the communication and the relationships that you have with your staff and your ability to demonstrate transparency and openness and trust in their judgments and in the need for their input as you go forward in shaping the policies. So even though the policy is not yet written, this is again at Santé Vitalité, the visiting hours are starting to change. So that's fascinating. So Christine, I don't see that anyone else is writing now. Perhaps we should turn it over back to you.
Thank you very much, Patty. So I think that Eleanor and Angela are really going to pick it up where Patty has left off, and we'll be moving on to our next section on communication and education. So Eleanor and Angela, over to you.
Okay, thanks, Christine, and Angela and Patty for that lead-in. It's Eleanor speaking now, and it's just so exciting to see some of the comments, and it's very clear that these teams are on the journey already with stakeholder engagement, and clearly you have already begun the processes of communication and education. And we're going to just dig in a little bit deeper into points that you may want to consider as you sort of proceed with the project. So Angela and I are going to focus now on communication and education specifically. And first, we really want to make the point that these two are not to be confused. And too often within organizations, there will be attention given to one or the other with the assumption that if you communicate something, people will know what to do, how to do it, and will be fully supported. Or if they have sat through an education session, that they will understand what their role is or how to do a specific function. And both communication and education really require very thoughtful approaches, and they will be slightly different. Communication, the two definitions are reflected on the slide, but the things that I want to pull out as the distinguishing part is that communication typically will include a message of information or news. So they tend to be more focused sound bites and not have the depth of information that individuals may need to fulfill expectations in the go forward. And education is that very systematic instruction that really results in a body of knowledge being required in a particular subject. So one, the communication will be more of the soundbite, and the education will be the deeper dive into the knowledge that people are expected to work with. The important thing with both is to recognize, if we go back to the NHS sustainability framework, both of these are a reflection of an investment in the people who you're going to be relying on to either design, to implement, or ultimately support the change that you are planning. So while each is distinct, there are elements that are going to be common to both and can be taken almost as a checklist as you move forward. And it really is that sort of fifth estate approach of, with communication, it's who, what, when, where, why, and how do you accomplish it. And with education, that same framework or approach can be taken, but they will take you into slightly different plans or detailed constructs. So the next thing that we're going to be looking specifically at is the communication. And what Angela and I will cover is what is entailed in a communication plan, what might be included as communication content as part of that plan, what are the skills that individuals may need to be able to communicate effectively, and then how can you assess the effectiveness of each of these. So with the communication plan, looking at the who, the first part is, as Patty has really beautifully elaborated on, you have to identify who your audiences are going to be. So stakeholders, there's been a lot of work on that stakeholder plan, and so the stakeholders are going to be part of your audience. There may be audiences beyond your stakeholder group, like that. When you think of an organization that has however many thousands of people, or that broader community in which an organization works, you realize that you cannot necessarily get that stakeholder impact from everyone, but what you can do is make sure that the communication is targeted in some fashion to reach out to everyone so they have the news or the information about what you're doing. So give consideration to those groups and how they are going to be important to your goal. Some will include professional groups, so that can be at an individual level or at a collective level. So it can be, you'll look at specific clinical staff or physicians who will be key to the process, or you can look at the medical advisory committees or the unions, the professional practice committees and such that will support. It can be at a unit level or a department level, and always give thought to when there are policies that are being developed that are very clinical in nature, there can be that leaping to that as your target audience, but look at all of the departments within your organization that are going to be expected to support whatever the policy process change is. And then obviously that larger community, and by that, look at your partner organizations, look at the patients and families who have been users of your services, and the community at large, which means everyone who at some point might be relying on your services. Another point to give consideration to that's actually not articulated on this slide, but I do want to touch on, is it's also important with your communication plan to look at who is actually going to be the messenger. So we're talking about targeting the audiences of communication. You also need to identify who it is that you are going to have as your messengers, as they are going to require specific communication and will be key to the success of your communication strategy. When we look at that communication plan and look at the what and the why, it's absolutely essential that time is taken to develop your key message and stay on message. This is going to take you into looking at what your statement of change is, or that aim that Patty talked about earlier, how it aligns to your corporate strategy, what the timing of the change is, and what you hope to achieve. And part of having your key message developed and staying on message is when you go out and knowing that there are going to be resistors, you will be ready to be sure that you stay on point and not get detracted or deflected into other issues. When you are developing your communication plan and really that what goes in your communication plan, you have to customize the plan with relevancy and to the expectations of your targeted audience. Often there will be creation of a message and it goes out broadly and people say, okay, we have communicated. But if the message is not being customized to target audiences, then there will be gaps or total misses or errors in the communication. So typically there will be a core message, but then you can customize it to what they need to know, what they can expect, what is expected of them, and how they will support it. And you can imagine if you put those 4 questions to the test in going to different audiences, the message is going to differ slightly. So imagine your message to a board is going to be different than the message that you're going to give to the frontline staff who are engaging very directly with the patients. And always a great part of a communication plan is to give thought to what you will anticipate as some of the questions and what you might anticipate as the messages that people need to take out. So we've all worked in instances where we have had the frequently asked questions documents given to us. Those are things that reflect a lot of forethought, and they also will be your own, as you develop them, they'll be your own test of have you thought of all of the nuances of what it is that you wish to communicate. With the where and the how, there are many channels and methods of communication, and there is not going to be any right one or two. You have to sort of do that, your own environmental scan to say what will work in your areas. But the obvious ones that will come up are one-to-one meetings or group meetings. It can happen in the course of a workshop. It can happen in a conference. That's not saying that's the whole education, but that's where you can land pieces of communication. It can be in correspondence, either in letter or by email. It can be done in leaflets that are left for staff to pick up or for patients to pick up in waiting rooms. It can be done with press release, which is a very broad media engagement, or using intranet. So because there are so many mediums now for communication, there's many tools, and you need to give thought to which ones will work most effectively. And as well as you're working through that communication plan, really consider and proactively address the risk and benefits of each. Because if things are left out, you need to realize that is a public, if messages will be sent out in a letter without the readiness for the press to be released, and the press become aware of it before you have managed a media presentation. So think of what those risks and benefits might be of the methodologies, and make sure you factor that into the plan as well. This is really showing respect for your different audiences and knowing that you want to engage them at the right time and in the right way. So in terms of the when part of that W5 and the communication plan, this is really looking at the timing and frequency. So ensure that your plans align to the time deliverables and the activities. And it's always a wise thing to, if you're starting that you want to implement something by a certain date, look at that date and work your communication plan backwards from that date. Because a lot of times we move into really wonderful work with a lot of front-end energy of the concrete part of the work, and then we come to the communication plan. And by that point, it may be too late to have communicated some elements to some of the individuals that would have really positively influenced the work, or to have the engagement that you're wanting. So just as with the stakeholder plan, you look at the timing of everything, your communication plan is basically a tool that is going to support that process. If you are using more than one communication channel, ensure that the plan supports the appropriate timing of each. So let's say if there's going to be a word of mouth message at the staff level, then having a written frequently asked questions document is a very useful tool to have as a companion document to take away from a verbal presentation. And the other really, I think, very helpful thing to consider with all communication is what's described as the rule of 7. And that is that it typically takes 7 encounters of hearing or seeing something, so the communication can be auditory or visual, but 7 times before it's internalized. So communication is a very ongoing process and can be refreshed and can be built on based on every lesson learned with the communication. The communication plan itself can be and should be a written document where it basically outlines the accountabilities for oversight and the steps. So if you know who the target audiences are, then it's who's going to be the messenger, what are the key messages, and it all gets mapped out so that you can always go back to the plan as a document that becomes your guide and checklist. With any communication, it is important to ensure that there are writing skills brought to the process. This is where a skilled writer is going to be able to help with the alignment of the message to the audience. And it will also be sure that the message is going to be heard in the way it is intended. So the skill of writing, it doesn't need to be necessarily a communication team, but you want to know that there is someone who has that writing skill that is part of your process. Similarly, you want to ensure that as the message goes out, that the individuals presenting the message have the skill of being able to present, to read an audience, to hear the questions, and can therefore manage a presentation of information. depending on the nature of communication, but in this instance, a significant change in a family presence policy is something that could hit a media attention. And in this instance, it's important to be prepared that you know who the media spokesperson will be and that they're prepared to do that. Many people will think it's a great thing to have to get up or have that opportunity to be on TV or on radio. And I can assure all that that's something that you want to know that you're going in ready for. All of this takes time, thought, and resources. And it's important to recognize that the time spent early up is going to be well worth the investment in terms of the product and the success of the ongoing project. So it should be seen as a factor in the rate of change and the support of change and sustainability. As with any process change, you want to be sure that you can actually assess whether or not you are landing where you want to be. So the possible metrics for this is if there's a plan, you've got an adherence to plan. And that's where if you know that you have got specific dates and audiences, you can check against that and basically have a completion against plan. If you're planning a certain number of sessions, then you have the metric of the number of sessions planned and the number of sessions attended or completed. You'll know who your targeted audiences are, so you can monitor the number and the percentage of the targeted attendees who are at the sessions. And this is going to give you the sense of whether the message that you're wanting to get out there is actually penetrating where you want it to within your organization. Another metric is the number of responses, the feedback that you get in response to communication. And that can be responses to emails, questions at sessions, hits on a website. And again, depending on the timing and the scale of the change, media coverage can often be a very successful metric, looking at the volume, the breadth and depth, and the tone, whether it's a positive or negative tone with the media presentation. It does sound like many people are well underway with communication, but if you check into the resource hub on the CFHI website, there are tools there that will be exemplars to you as you continue the work. Kingston General Hospital developed a program when they were engaging the leaders and staff within the organization in developing their communication plans. They developed an entire toolkit on how to communicate and develop communication plans within the organization. So that is available on the website and on the CFHI Resource Hub and has been translated. And then there is an example of the Providence Healthcare communication plan that we heard about on one of the earlier webinars. So that's Providence Healthcare in BC. Now I'm going to turn it over to Angela, who's going to speak in more detail about communication and the individual skills that are necessary to support an overarching communication plan. So Angela.
Great. Thank you, Eleanor. So just as education and communication are different, there are two distinct communication factors to consider as you work on this change. There's the communication strategy around the policy itself, which Eleanor has just discussed, and then there are the individual communication skills. These are the communication skills that will be extremely important as you introduce this change in planning and practice of the policy and in growing a patient and family-centered culture within the organization. The ability to convey and assess messages is done through verbal communication, nonverbal communication, and active listening, and all are critically important to partnering with patients and families. My friend Bonnie was going through cancer treatments, and we were a bit of a team, so I was with her for many of her appointments. And one day I went over to her house for a visit, and the home care nurse suggested that we should be setting up an appointment with Bonnie's palliative care team. She had noticed a change with Bonnie. So we set up the appointment and went in, and this doctor was, a favorite of Bonnie's, and he sat down across from her, He looked into her eyes and he asked her how she was doing and how she was feeling. And she said, I'm feeling pretty good. And he said, are the pain meds handling your pain? She said, yeah, they are. I'm a little tired, but otherwise I'm feeling pretty good. So he then turned to me and her husband, and he's looking at us quizzically as if that's, so why are you here? And I said, Bonnie, tell him about what you saw the other day when I was visiting you. And very matter-of-factly, she tells him, oh, yeah, there was the cutest little Mexican cowboy riding this little miniature horse around my house. And without missing a beat, he says to her, how did you know he was Mexican? And she laughs and she says, well, he was wearing a sombrero. The doctor turned, smiled, looked at us, and said, yep, we need to adjust those meds. The doctor set the tone for the interaction with us. He spoke in a calm and kind manner. He explained things in a way we could understand and relate to. Sorry, I'm going to just go back one slide. There we go. It was a conversation not just with Bonnie, but with me and her husband as well. He was able to relieve our anxiety. We felt confident that he had the information he needed to help us make informed decisions about her care. We knew the plan, and we felt safe. In contrast, Bonnie had another physician who I'm sure was highly skilled and competent, but Bonnie absolutely refused to see her. The doctor spoke really quickly, sort of like she was thinking out loud, like she was relaying the information without any concern for whether Bonnie actually understood the information. And Bonnie would just sort of sit there and nod and agree, and the doctor would walk out, and then she would turn to me and she'd say, what did she say? She felt confused, anxious, uninformed, and after those visits, she said it made her feel dumb. So she insisted on a new doctor. It's not just what you are saying. It is how you are saying it. Just because you've said it does not mean you've communicated it. This applies to partnering with all stakeholders. More than 50% of communication is nonverbal. If you're not looking up from a computer screen, you sigh heavily, you roll your eyes or shrug your shoulders, you can be saying what you want to help me, that you want to help me, but I'm not going to believe you. Nonverbal body language can completely contradict what you are saying. But good nonverbal language, like leaning in, nodding, looking me in the eye, smiling, can show understanding, tenderness, caring, and respect without saying a word. Nonverbal clues are also helpful in assessing a patient and family member's needs. Often a family member will say that they are fine as their eyes fill with tears. But if you're staring at a clipboard, you might not even notice. Active listening means actually listening, showing interest, asking questions, and listening not just for the facts of what the person is saying, but also for the emotions or the nonverbal clues. It's polite, builds trust and rapport, and helps to provide information you need to be fully informed. When Bonnie said she had a cowboy riding around a miniature horse around her living room, the doctor did not even blink. He just calmly asked 4 questions as if that was the most natural thing in the world. All of these communication skills may seem obvious to you. You may assume that your staff and leaders have these skills. Healthcare workers often will say, of course we do that. But just because we know we should do it does not mean we actually do it. It would be a mistake to assume that your staff and leaders have these skills. When you become aware of how important these skills are, you will also become aware of how often they are not actually demonstrated. They may appear to be common sense, but often they are not common practice. I was facilitating one of the Communicate with Heart classes, and we were talking about how important it is to make eye contact and use the person's name when you introduce yourself to a patient. And one of the staff got kind of emotional, and she shared that when we changed the name badges at the hospital so that they were easier for patients to read, she had noticed staff started using her name. She was emotional because she said for a really long time she would walk into a room and her coworkers would just say, here's X-ray, kind of like being called the gallbladder in bed 4. Developing these skills will make a difference to the success of the family presence policy. It makes people's jobs easier when they have the tools they need to deal with stressful, emotional, and difficult situations. Providing resources to support the development of those skills creates expected behaviors of communication, not just with patients and families, but with each other. In the NHS sustainability model, this would lie definitely firmly in the people domain, but also be interconnected into the organizational and process domains. It increases consistency and awareness amongst staff of the impact that they are having on every patient and family member, and an understanding that their role is greater than the tasks associated with it. This slide mentions a couple of approaches that have been developed. At KGH, we decided to use a version of the Cleveland Clinic's HARP program as a resource for teaching, caring, and compassionate communication in the organization. Over time, that program has evolved and been adapted to meet the needs of the staff. Like sustainability models, there are different resources to choose from, or you can create your own. But this is a key factor not to be overlooked in the formulation of a family presence policy and practice. This brings us to our break. I'll turn things back to Christine.
So thanks very much, Angela. And we are approaching our break, but of course wanted to leave time for questions and reflections on this part of the webinar related to communication. So I will invite anyone to type into the chat box if you do have questions or comments. And then following that, we will see where we are for time and take a break. So I'm not seeing anybody typing any questions in. With that said, we can go to break. Of course, type in any questions you may have at any time. So this brings us to our break. We are going to go with a 5-minute break. The time now is 1:13 p.m. So we will rejoin back at 1:18. And during this break you will hear music, so don't be alarmed. We will sort of turn back on and become engaged once again in those 5 minutes. So we will see you in 5. Okay, so hi everyone, it's Christine again, and we are back. I do see a question that's come in from Shum, just asking for a reminder, where in the desktop are the communication plans from Kingston and Providence? So I believe I've included the resources for Kingston within your Phase 2 webinar materials, so you would locate those in the same place as you have done to access your webinar, and you can find that most easily by following the e-Collaborative schedule quick link on the right-hand side of your homepage. For the Providence Healthcare one, this is included in the resource materials from the affinity call. I believe this was affinity call number 2, so similarly, if you'd like to access the communication plan that was shared and translated from Providence Healthcare, you can do that by going to your quick links, clicking on the e-Collaborative schedule, and navigating to the affinity call, and there are resources listed within that web page. If you do have questions or comments or are unable to locate it, I can certainly help you out one-on-one by email or by telephone. And with that, thanks for asking the question. Okay, and there was a comment that Eleanor was posing to Vitalite. If you had more to share about what you're seeing in terms of culture change, we'd really like to hear from you. It is exciting when you start to see those signs of change. So if you had anything else to share, we'd certainly welcome your comments and observations and can put that out to the group as well. For the next portion of our webinar, we are moving on to education. So we've touched a little bit on communication. Building on what we've been talking about around communication, we'll be moving to education. So again, over to Eleanor and Angela.
Great. Thank you, Christine. This is Angela again. So we're going to move on to this last key factor around education. And why are you creating a family presence policy? What should be on the curriculum? How, where, and when are you going to teach it? How are you going to assess the effectiveness of the education itself? And finally, how can patients and families be included? Education will connect to many of the factors in the domains of the sustainability model. Family presence is about partnering with patients and families in their care, and I believe it is archaic to think that an organization would separate patients from loved ones in their time of need. It is the right thing to do, and we all know if our child or loved one needed us, we would be there regardless of the visiting policy. Staff and leaders need to connect to this policy in a visceral way, and communication, education, and the sharing of patient stories will help that to happen. Having said that, however, not everyone will get this or support it from the beginning. It challenges the status quo. It is critical that there is a common and shared understanding of the change, why it's being implemented, what the expectations are, and how it will be supported. Education can help to connect the change to intrinsic motivators, enable consistency of practice, and create that shared vision that Patty spoke about earlier in the presentation. Education will help connect the policy to a change in behavior, to improvements in their work, and the important role they play in the experience of patients and families on an ongoing basis. Education makes it real. Eleanor is now going to move into more detail about this and for you to consider as you formulate your education plan. Eleanor?
Thanks, Angela. And I do want to build on that why, which really is focusing on ensuring that everyone has a shared knowledge base to support change within an organization. So the next part of the who, what, why, where, and when is who gets the education. And with this, you need to give consideration to a number of elements. Obviously, there's going to be that education internally, and you're going to want to ensure with this sort of policy change, the entire organization being given education to some degree, because it will be a corporate policy, and things can unravel so quickly if there are parts of the organization that are unaware of what it is that is being changed, why it's being changed, and how they support it. So in looking at the entire organization, that's all employees, all credentialed staff, the volunteers who are a key part of an organizational human workforce, and all learners coming into the organization. Internally as well, the patients and families and patient advisors need to have an awareness. Again, with more in-depth than the mere communication of a change, because they'll need to understand how they support it, what the expectations are. And the education is basically that is internal. There has to be a basic education for all, and then it becomes customized where there is additional need and expectation for very specific knowledge and response. So it's understandable where the education of registration staff may differ from the education that the nursing staff that are in the clinical areas or the security team who have to respond to issues will get. So it's being thoughtful about the targeted audience and then how it gets customized, but there must be a basic education. Externally, there will need to be education as well. It won't have the same depth as what you might do internally, but you, depending on who that external partner is, it may have similar content and detail. As example, academic partners who are placing learners within your health setting, if they receive a comparable education to those who are having internal education, that will actually begin to change their organizational approach and mindset and the way that they will be able to support what you have established as an objective. You know your environment, so you will know who those that education plan is going to be built for. But those are illustrations of who you might focus on. I think one of the key parts with the education is to also, as you identify who, identify whether it is mandatory or optional. And one of the experiences we went through at KGH is because of the nature of the change, we made the education mandatory for all of our staff and the volunteers and advisors who were part of the process. We did not make it mandatory, and we can go into the reasons, or it was not mandatory for the credentialed staff. And that created a disconnect in the nature and the timing of support for some of the changes. So I think that ideally with certain policies, it is going to be mandatory, and that's going to drive how you support the education of different groups. And I will touch on that in a moment. But the question about who is whether it's mandatory or optional as well. When you're looking at what the education is, there are going to be a number of components that should just be built into a basic curriculum. Again, with customization to the audience, but certain things should just be there and touched on to some degree. So I'm going to go into a bit more detail with each of these, but the curriculum could be made up of patient family-centered care, what it is, patient-family engagement, what it is, details about the policy and the practice change that you're launching, what the required competencies are, what some of the supporting processes are, and other things that might emerge as curriculum needs within your organization. Very important point that I think Angela always helps with reinforcing is that the content, regardless of the format, ought to be developed with the input from and in partnership with the patients and families. They will enrich content without question. The curriculum then specifically around patient-family-centered care, this is so key to have because we will always think that we're talking about the same thing when we talk about patient-family-centered care, but as you proceed with this process, you are going to see that some people will understand patient-family-centered care to be one thing, and it may be based on very old knowledge and learning. And the education becomes key to ensuring, again, that there's that ground setting or leveling of a baseline for all staff within the organization. So patient-family-centered care, this aspect of curriculum can include what it is, and there's lots of resources out there and different ways of describing it. Each organization can suit what's appropriate to them, but there's having that definition of what it is within the organization, how it aligns to strategy, detail about what some of the benefits of patient-family-centered care are and what some of the outcomes are, what the barriers are and what the enablers are. And again, you knowing your organization, you're going to be able to fine-tune this with knowledge, but also build on what has been made available through, again, the CFHI hub or through other resources that you might have who have gone and proceeded in other instances with patient-family-centered care education. The curriculum should also focus on patient-family engagement because there is a difference between what patient-family-centered care, which is an approach to care, and patient-family engagement, which is a means to developing and designing that approach to care. So you want to ensure that people know what that engagement is. It's meaningful connection of care providers with those who utilize the services and are ultimately the recipients. And in describing the importance of patient and family engagement, it's to describe why has it changed, what has changed to make engagement such an expected and essential part of healthcare. You can talk about why it is important. Again, the value proposition will be to patients and families, to staff, to organizations, and you can build these in. And we've shared the Carmen framework with you so that you can have an understanding of categories and levels of engagement so that staff can see where they are and also where they can move to in terms of changing the nature of engagement with patients and families. And in the context of this specific policy, it's describing that family presence is a key enabler to being able to engage in a meaningful way with patients and families. So this part of the curriculum can start at the high level in a very general way, but always be taking it to tag it to the organization so that it resonates with your audiences. The curriculum is also going to need to focus on what some of the required competencies are. For there to be patient engagement and to the good end of patient-family-centered care and supporting a family presence policy, individuals are going to have their own self-awareness. They're going to have have an understanding and heightened exposure to what empathy is and how that is going to influence the nature of the engagement and partnering with patients and families. They're going to have those communication skills that Angela described. So education, like required competency on verbal, nonverbal, and active listening skills is an essential part of the curriculum. And then also at a personal level, how to recognize and move through conflict resolution. So that's the personal skill of conflict resolution. With the curriculum, in addition to the personal competencies, they're also going to have a knowledge or require that knowledge of what the supporting processes are. If staff don't know how to support secure 24/7 access and what the points of entry are, regardless of hour of day, then they're going to be less able to authentically and confidently support messaging to family about family presence. There also needs to be processes put in place for staff as to how they will balance patient needs and family presence. And certainly when we first presented the family presence policy to our nursing practice council at KGH, it met huge resistance because the staff felt that it was just going to be overwhelming, that there was going to be an overrun of the number of individuals who would be staying, that they would be staying at all hours. It was going to create lack of security for them and patients in the small hours. So looking at how, or that there would be, 20 patients in a room where another patient had no family presence, and how would that affect the patient that had less family to be present. So the knowledge and skills of how to move into the balancing of meeting patients' needs while supporting this as a corporate policy intended to do good for patients. Staff will need to understand security contact and response. They need to know how they get security quickly. What is the process within the organization? It might be a buzzer. It might be the handheld communication devices such as Voicera. It could be an overhead paging. Those things need to be detailed so that staff have that knowledge and are able to move in immediately to support. Where I mentioned conflict resolution at a personal level, that's absolutely essential. But the staff also need to know that if conflict cannot be resolved at a one-to-one level by the provider, that there is a process that can be escalated to ensure that there will be resolution of the conflict. But that process needs to be developed, and staff need to be aware of it before they are being asked to support some of these changes. So the next section of education is looking at the how and the where. So again, the methodologies can change or vary. So you can have those with online learning systems. You can have a self-learning module that can take staff through this at their own time, own leisure, with an assessment of competency at the end of it. It can be done in the classroom. It can be done with written materials, like hard copy materials. It can be reinforced with one-on-one education or through precepted education or anything that is enabled by roles within your organization, such as clinical resources or nurse educators. And the capacity for education, recognizing that we're saying that education has to be very broad into wide audiences, the concept of train the trainer programs is another thing that can be considered. So the methodologies will vary. The thing is to, again, look at your organization and what the infrastructures and tools are that are available and optimize those. With the delivery of education, ideally, with presentations, these will always be shared presentations that bring the patient voice along with a organizational champion to educate to the value and the processes and reinforce the importance of the partnerships. The consideration with the design of this education is, again, to always protect the resources and the timing for staff attendance and the materials that will be developed. Education is not something that can be done quickly or off the cuff. but it is, if well-timed, it can be done in a manageable way that doesn't have to break the corporate bank, but delivers on the expectations. And then the final component of the who, what, when, and that is the when. So the very important part is education, as with communication, as with stakeholder engagement, as with change, is iterative. So you can begin education early on in the process. You just need to determine which components are going to be delivered when, and how does the education plan support the change process. So I would expect that some organizations have already moved forward with the education around what patient and family-centered care is, and that's going to be a foundational piece of education to gain the support for a change in a family presence policy. So design and deliver that change at optimal points. It can be done with the implementation of change as well. It can be done with the performance review and the management. So one of the key parts, and patients and families are very good at teaching this, that you can go a certain course. What you want to do is be able to hear if it's working well and to course correct if there's an opportunity to do it better. So you can start with the education, and where you find that there are knowledge gaps or need for heightened emphasis on certain points, then you can modify that plan as you go through the review. Education on some of these components can be done with orientation or the onboarding of new employees, credentialed staff, learners, and volunteers. And then again, it's that point of it's the rule of 7. Education will not happen with one encounter using one modality. Education, there has to be that the different ways and timing of hearing messages to reinforce and really have some of it internalized. So it's that ongoing process, and again, there's that encouragement that you go slow to go fast. The investment in education up front will definitely assure greater success and best use of resources moving forward. And with other aspects of change, you're going to want to have some assessment of whether your education is meeting the plan and expectations. So metrics could be, again, that adherence to an education plan. Have you sort of hit the timelines and the audience that were seen to be key to the success of the initiative? What were the number of sessions that were planned, and were those sessions successfully delivered? What were the numbers and the percentages of targeted attendees who were at the sessions? With education, you always have that opportunity to provide evaluations of the education. So the feedback from the evaluation of education sessions will help you with your course correction where needed. And then with education, if you're educating to a specific topic, then ideally building in practice audits that look at the reflection of the impact of the education will tell you whether or not the education has been internalized. Education is a point-in-time process. What you're wanting to do is see change in behavior as an outcome of the education, and these practice audits are definitely a means of giving some assessment on that level. And now I'm going to turn it back to Angela, who's going to elaborate on ways that patients and families can be part of this very critical part of change and sustainability of success. So Angela.
Thanks, Eleanor. As we mentioned earlier, patients' stories and experiences can drive change, connect behavior to policy, help overcome barriers, and pushback. Patient advisors have a perspective that can help bring this policy to life. They can partner in the methodologies and delivery of education that Eleanor has outlined and they can partner on the creation of communication tools both internally and to the public. They can help people understand that this is more than just getting rid of visiting hours. They can provide scenarios and experiences for staff training. They can participate in presentations and role-playing to reinforce the why. They bring a different lens to policy creation and reviews and can help identify patient experience and measurements of success. They can play a very key role in education. All of the factors we discussed today will help to ensure that staff and leaders in your organization will feel heard and supported. They will take pride in the policy and practice that is developed. In the process of carrying out their daily tasks, staff can forget how significantly they are impacting a patient and a family at a really important time in their life. Little things can have a huge impact. Little things like a smile, a welcoming gesture, a kind word, and a positive attitude can make the darkest moments a little brighter. People may hear the words family presence policy, but they will feel how it is practiced. Implementing a family presence policy is so much more than just another new policy. It is transformative. Building a strong foundation will ensure its success. Back to you, Christine.
Okay, so thank you very much for ending on those words, Angela. I think always important to remember why we are here and really sort of getting at the heart of family presence and reminding us of that. So we are now back into our question reflections. If there are questions that you have about what you've heard around education or other subject matters, certainly we would welcome those by chatting into the chat box. So I will just give a moment for that before we move on to next steps. So Angela's just chatting in, and I echo her statement. We would like to hear how some of the patient advisors on the call are being engaged so far. So if anyone would like to be brave and chat in to share a little bit about how patients are engaged, and if there are patients on the call, we'd certainly welcome hearing from you. So comment from Kathy Stevenson, who's saying that Carol, one of their patient and family advisors, has been with them since they've started, and they are reporting back to each PFAC meeting every month to get the feedback from the PFAC. So nice to see that integration, and thanks for Carol and to Kathy for sharing that. Okay, so Annie is talking about some of the sharing of patient stories, and I like the word, how you're talking about training in tandem, if I'm translating directly, and also providing some advice on the documentation. Really encouraging from Jenny and team at Vitalité. We have a patient on our team, and it made, in capital letters, the difference. Really good experience to replicate or duplicate on different policies and procedures. To hear this experience was really positive to all team members. That's really encouraging to hear from all of the teams who are working with our patient and family advisors, so that's great. Eleanor was also asking a question. Any experience or advice from teams with communication and education of physicians? So we'll pose that question right now if anyone has any responses to Eleanor's question, just about your experience or advice with communication and education of physicians. We know this is an important stakeholder group, so looking forward to your responses. And from Sophie, one of our coaches, she just wanted to share an experience related to family presence. And once they implemented family presence on one of their sites at the MUHC, they had forgotten to include their security services in the communication plan. So there's a little bit of confusion about what the actual policy was, as they had forgotten to include them. So a nice reminder about your different stakeholder groups that you'll be engaging. And if I could add to that, the other people that sometimes are forgotten is really your the people who answer the phones at your organization. So often family members will call in and ask what the visiting hours are. So don't forget to include and communicate very much to your front line and your switchboards if that's not something that you've done already. There's a comment, great comment from Jenny about sort of that one-on-one or face-to-face seems to be an appropriate way to engage physicians so they can speak right away about their experience and have the opportunity in a safe place to talk about that particular idea. And again, reinforcing that they really like to be part of the decisions. And so I'm imagining that the importance of bringing them on quite early will be helpful when you're speaking of engaging physicians. Angela, just adding to the conversation about ongoing education as new people come on board. So I think we touched on that a little bit related to some of the communications and educations work. So really important to start thinking and looking ahead to the sustainability of your project. When you are developing your training for staff, how are you going to continue to integrate that into new staff onboarding once the policy is in place? Okay, so I see there's a couple more comments coming in. Please continue to chat those in and I'll circle back on those. In the meantime, I just wanted to go to our next live event slide. First and foremost, just a reminder to you and your team, have you completed your end of phase 1 survey? If you haven't done it already, it's not too late, and we are including the link so at least one person on your team can begin to fill those out. This is our end of phase 1 survey, and it's our expectation that people who are listed as part of your steering committee and or your implementation team are completing the survey, and this really helps us to continue in our ongoing planning and to understand what difference the collaborative is making to you as both individuals and a team. So please, if you haven't already, it's not too late, complete your end of phase 1 survey to give us some feedback which will inform the design of the collaborative. Looking ahead to our next affinity calls, we will be back together at the beginning of October for our affinity call 3. It's my pleasure to let you know that we will have somebody from Saskatchewan who will be joining us to share their experience with moving to family presence province-wide. So very much looking forward to that. And certainly we are taking your feedback if you've participated in I call it the lobby question, the question that was up at the beginning of the webinar. We're going to be taking that information, and it looks like patient engagement. I saw some particular piece around patient engagement in long-term care, I believe, as well as change management, continue to be topics that are of interest to the teams. So we will be modeling our coaching call on October 13th around those domains. And again, coaching calls are really that opportunity that allows you to network and exchange both with the coaches that we have as well as the team. So please come prepared with the questions that are listed in your coaching call document on the desktop, having reflected a little bit about your challenges, your barriers, and what's been working well. We do have our next affinity call number 4 on November 22nd. So again, another touch point for us there. And thank you everyone for your communication as well as your interaction on the call today. Just circling back to some of those last comments, I see one from Eleanor, the importance of engaging your Chief of Staff or VP of Medicine relating to physician engagement. And really engaging that group, it's a great way to get input on how to tailor your education of credentialed staff. And from Eleanor's perspective, with KG8, they learned that they would support it if they could do it online, and ideally if it was related to CM8 credits. Difficult to land that change, but engaging that level of leadership and relying on their accountability was really helpful to teams that were implementing. So thanks, Eleanor, for sharing that. And I believe Jenny had one more comment that I'll read for our French folks as we're translating, related to the education for physicians. Good point, it has to be short and right to the point. It's not possible to do education for 3 hours as they're not going to buy into this idea. So with that, this does conclude our session today. I wanted to thank our faculty who have worked with us to develop the content, as well as our coaches who are here to support us both in this call and through coaching, whether it be individual ad hoc coaching or on the coaching calls. I certainly would like to thank any patient and family advisors who are on the call today, and please thank them for us for their participation if they are unable to join us today but are part of your team. We're really starting to see sort of what difference working with family members and patients really do make, and it's really encouraging. So thank you for your participation, and of course thank you to everyone on your teams for taking the time today. We know 2 hours is a lot of time, but it isn't a lot of time to cover the amount of content that we're hoping to share with you. So we hope you've gained a little bit of insight into some of the topics that we'll be working through together in Phase 2 implementation. And with that, this does conclude our webinar today. So have a great rest of day.
Thank you. Ladies and gentlemen, this does conclude the conference call for today. You may now disconnect your line and have a great day.